Dear ladies and gentlemen, good morning, China, good morning, Europe. Good afternoon in Asia.
Good morning.
Good morning.
Morning.
For this session, we will have 4 speakers. Dr. Damras Tresukosol from Thailand. Let me see. I think the connection from a laptop is unstable. Give me 1 more minute. I need to zoom in. So this afternoon, we will have 4 speakers. Dr. Damras Tresukosol from Thailand, Dr. Joško Bulum from Croatia, Dr. Roberto Garbo from Italy. I think I have been to your hospital a few years ago, and also me. Also, we appreciate BrosMed to provide this opportunity for us to communicate each other. So it's my great honor to invite the first speaker, Professor Damras Tresukosol from Thailand. Damras is a very well-known PCI expert, and he has done many complete cases of PCI. The topic of presentation this afternoon is a complicated functional occlusion, proximal sync flash with large intramural hematoma of distal left main carina. Please, Damras, go ahead. Thank you.
Okay, can you see my screen now?
Yes, we can.
Okay, so this is a bifurcation part PCI the strategy meeting. Okay, the pitfall of stent assist PCI is the stent edge dissection, mostly from pre-dilatation with stent not fully coverage. And second, direct stenting may help to avoid the dissection flap at the edge. But sometimes direct stenting is not possible because of the friction or calcification inside the vessel wall. And both distal and proximal edge may help the tissue optimization technique, or OT. OT can be proximal or dot distal. And it can solve the unexpanded stent, taper vessel, and optimization part or dot. So this is the OCT finding of where we are quite commonly seen for post-stent PCI. On the left panel is the dissection flap just distal to the stent edge. And in the middle panel is the stent mount position by OCT that is much clearer visualized compared to IVAS. In the lower panel is IVAS, the upper panel is OCT. And the third one is tissue protrusion and or thrombus that is protrude inside the vessel. And we need to solve this issue. And one of the new challenging device is pod balloon. So my present case, first case, I have 2 cases to share with you. First case is a 53-year-old man with atherogenic risk hypercholesterol, hypertension, impaired fasting glucose, worsening effort angina, less than 2 months. Had treadmill positive test and calcium score is only 56. So this is a right correct angiogram. You can see diffuse disease, but not significant. The more significant is on the distal RCA before the diagonal branch, and some on the osteo of the RPD. And this is the collateral from the RCA to the LED. And this is the angiogram on the left coronary artery. You can see functional occlusion of the circumflex around here. And there is diffuse disease on the LED. This is the diffuse disease of the proximal to mid LED. And when we measure by using QCA, this is by the Tomcat QCA, you can see that the diameter is around 2.64 And the distal reference is 1.9, the mean reference is 2.3, lesion diameter 0.8, and lesion length is around 40.9 millimeters. So this is QCA contour. And again, we do the same at the osseous circumflex. So in this circumflex first, you can see that osseous circumflex, there is not such a significant lesion here. So we pass in with serum Y, and we do initial balloon with the 2/15 Rilrai balloon from Terumo. After we do the balloon, we do OCT. And this is the OCT finding. So the lumen diameter of the shoulder is 2.5. The proximal shoulder is around 2.2 by 2.36. And area is 3.67. Osseous circumflex, the area seems to be small, 2.6, compared to the angiogram that is not significant. And again, mid left main area is only 2.97 that we cannot see clear on this image. And this is EM area and EM diameter. So we do the balloon first. So this is the balloon. It's quite difficult to cross the lesion. You can see that you have to push. When we push, the guiding is flip up, and then we cross the lesion. And after the balloon, we do the OCT. So this is the OCT finding. I scroll fast a little bit to see from this image. So this is the distal shoulder, the OCT finding of the circumflex artery. We scroll until here. Now you can see that this is the minimal lumen area around here. And to the left main. So this is the minimal lumen area of the osseous circumflex, and this is the most severe of the circumflex site. So at the area 50 is the osseous circumflex before enter into the left main carina. So on the circumflex, this is the extrapolated EM of the lesion. The lesion is very tight, and this osseous circumflex. And this is mid left main, that is 1.92 by 2.78, and area is 2.9. And this is the left main body, 3.14 and 3.73 by lumen diameter right here. So this is the area that we are tending to focus on. So after OCT, we do more balloon with the NC to 5 by 15 Sprinter, and then to 5 by 28 Sans Sierra. So this is a stent placement. After we place the stent, we do pot with the 2.5 by 15 NC Sprinter. This is stent boost to show exactly that the stent is not expanded at the proximal edge. So we do more by pot using 3.25 by 6 NC active force here. And then after that, we cannot cross with dragonfly. We cannot cross the stent on the circumflex. So we don't know why. So we do more. We switch Y and cross. We do more balloon with the 2.5 by 15 of the osseous circumflex. And we open another new dragonfly upstar. First, we used to optis, could not cross. We change to upstar, and then we cross. So this is the OCT of the findings. So we start from here. You can see that the stent is quite well expanded with some minor tissue protrusion inside the stent. The stent contour is not well circular. And I drag a little bit faster to show you that there is some disease here. You can see that on the 11 o'clock on the cross-sectional view of the OCT. You can see that there is the big intramural hematoma around here at the carina. And this is the carina. This is the LED opening on 11 o'clock. So this is the intramural hematoma just on that. So I go back a little bit. This is where the dissection happened at the proximal stent edge. Some dissection around here, and that start with the intramural hematoma around here, and more severe on this freeze frame that I took from the OCT longitudinal run, hematoma and dissection. So what we are going to do here, we change the strategy after OCT. Because there is mid-left main lesion, MRAs are 2.8 to 0.9, and we need to treat this left main because MRA is less than 5.5 square millimeter. That is significant. Due to intramural hematoma on the ostial, we have to send this left circumflex to left main. But I plan to leave it right now, and we focus on LED to left main first. In this case, I select Q-lot to make sure I get dependency of left circumflex, left main, instead of the more favorable decay crush. I use Q-lot because I want to secure the ostial, the circumflex hematoma. So we OCT on the LED. So this is OCT from the LED. So I pass a little bit faster. Because the downside, you can see nothing because of the tight lumen. And now this OCT on the LED. It is a fibrotic plaque along the vessel. And this carina to this circumflex, and then the left main. You can see that there is the disease on the left main also. I'm going back to show you the disease on the here. This is on the mid-left main, that is 2.8 to 0.9 in square millimeter. And this is at the carina. You can see that at the carina, there is a big calcium at 11 o'clock. That is the calcium to the circumflex side. So this is a complex bifurcation indeed. Okay, from this OCT, this is a freeze frame, carina, calcium, carina, the circumflex. Ostial LED, that is very elliptical shape, and this mid LED where is the tight lesion occur around here. So we do balloon first with 25 by 15 NC splinter, and then I place superflex cruise to 5 by 38, and post-stent inflation with the same NC balloon. So then I proceed for next. So we use the MAT strategy. MAT, I put the capital letter S, a bigger one, because I want to treat this distal left main by putting a stent on side branch first. So M mean main first, A mean main across side, D mean distal first, and S mean side branch first. So for main first, there is only one stent that is not available right now. It is access to treat this bifurcation, M first. But normally we treat A, main across side. In this case, I use S first, side branch first. So what I proceed, I could not cross the 35 by 18 sin Sierra to the circumflex. So what happened, this is after NTG, we see that there is a pinch lesion on the ostial circumflex because of the intramural hematoma. So we put body Y, and then we pass the balloon. We cannot cross the Sierra. We pass the balloon in with the body Y. This first Y, this second Y, and with the balloon. And then after that, we still could not cross San Sierra. All catheter was flipped out when we tried to push in. So I tried to push the stent in. And it cannot turn over the ankle. It is more than 90-degree ankle. And everything was flipped out, then I have to restart. So when I restart, I put in the guide plus for mother and child stent crossing. In this fixed image, you can see that this is the tip of the guide plus. After I pass this guide plus to the distal left main, then I can push stent through before pull back the stent to the circumflex. So this is the guide plus. I show you once again. It's a short video. So you can see that the guide plus is here at the tip of the stent. And then we push the stent through the tip of the guide plus and then pull back the stent to cover left main circumflex overlap with the first stent. So after we deploy the stent or the circumflex to left main, the stent contour is 25 by 28 and 35 by 18 Sans Sierra. And after that, we do post-stent inflation by 3.25 by 6. Note that the balloon marker distance from the marker is very, very, very long. And then after that, we because of larger left main caliber, so we pot. Now we use the pot PCI balloon that I prefer. Like right now is my workhorse, the pot balloon. This is a 40 by 6 NC pot PCI balloon. You can see that the balloon shoulder to the marker is very, very short and very, very accurate. So I do pot on the left main. This is the angiogram after pot to the left main. And then we place the pot balloon into the carina to the LED. Pot left main carina, and this is the gap between the LED stent and left main circumflex stent. And after we do pot here, we're going to balloon this and stent from LED to the left main for Q-lock. So this 25 by 15 rewrite to open the strut on the left main circumflex stent, and then the pass 35 by 18 Sans Sierra. And the trap, you can see that this is at the stent on the left main LED, the circumflex Y was trapped. So we pull back this circumflex Y and pass into the circumflex once again and do the pot here. You see that the pot marker, pot PCI balloon marker is very, very close for the balloon to the marker. So this is where we rewire the circumflex. And then we do the pot, do the post-inflation to the stent, and we do OCT. So after OCT, we do kissing balloon inflation, 35 by 12 NC track on both branch. This is the 25 by 6, 35 by 12, and last pot 40 by 6 pot PCI balloon. So this is the final result. This is spider view, show a good, very good result. This is OCT for the circumflex to the left main. I let the OCT run. You can see that the stent is well approached. There's no edge dissection on the edge of the left main, and there's no stent malposition. That is good part of the pot. And again, this is OCT from LED to left main. So we start from here. So this OCT from LED back to left main. And again, at the carina, this is carina. You can see that we have the stent good position to the left main, no malposition, no edge dissection. So I'm happy with this finding. And this is my summary of first case, copy lesion proximal 1/3 circumflex. Osteosurface lesion by OCT only, by angiogram that is insignificant. And post-POBA intramural hematoma, we convert to Q-lock, and we start from side branch stent first. And we have the larger left main caliber, and we need pot. And pot PCI will be our workhorse balloon for pot due to accurate balloon marker. And case number 2, 70-year-old man, diabetes, hypercholesterol, hypertension, and renal disease dependent on renal dialysis. In 2003, he had PCI on RCA and LED. And 2015, valve replacement by tissue valve and root replacement because of the aneurysm of the ascending aorta. So he had placed the PE graft, and for graft lima to LED and vein graft to RPD, RPL, SY graft, SVG to diagonal, SVG to circumflex. And in 2015, the same year, he had EVA for infrarenal abdominal aneurysm. And he presented just a week ago because of heart failure. no symptom, no chest pain, but heart failure symptom, and elevate troponin I up to 13,000, CKB of 262. So I make diagnosis as a massive myocardial infarction. EF dropped from 60 to 37%. CT was done, only patent Lima to LED, and other graph was all occluded. So this was an angiogram done just only 3-4 days ago. So this was the proximal LED, left main LED with very tight lesion, and the tight lesion here to the diagonal branch. This is the previous the LED stent. So there was ISR type 4 on the LED stent. And this was Lima to LED. That was patent and give good anastomosis to LED. And this was his native RCA. You can see that there is a lesion here, and tight lesion on the RPD. So very small. And compare the reference vessel of the RPD and distal RCA was totally different. Again, RPD and distal RCA. A lesion here. So what we did, we do balloon first, balloon on the RPD to RCA, and then we cannot cross the stent to the RPD. So we have to do the balloon to RCA and put the stent on the proximal to mid RCA first. Otherwise, we cannot pass the stent to the RPD. So this is stent on the proximal to mid RCA. The stent cannot cross the bending lesion around here. This is our stent placement. We can pass the stent to the RPD, to the RCA. And this is after we deploy the stent in the RPD into the distal RCA. You can see that the stent was not expanded here, thick calcium on both sides. So this is the balloon for post-stent inflation, stent boost. And now we pick up the 3.25 by 5 pod PCI balloon. You can see that there is a tulip contour. This tulip contour on the edge of the stent. So we do the pod on this taper vessel. And we use stent boost to guide balloon pod placement to the RPD. And this is a final angiogram result. It's not perfect. There's some pinch on the RPL, but it's okay. The very difficult case, and because of the LV function is very poor, and he had only Lima to LED present. And on the way back, we look at the EVA. You can see the tulip contour of the EVA because it was placed on the neck of the aneurysm. And this is on the way back to the right external iliac artery. We found friction around here, and we say that there is some disease, but we do not touch. So in summary to this case, pod PCI balloon is useful again for proximal optimization and also distal optimization. And distance between balloon tip and balloon marker is very accurate and avoid distal stent dissection in most cases. Thank you very much for my presentation.
Well, thank you, Damras. Very interested in 2 cases. So I think we will have 5 to 10 minutes for our discussion. So any comment or question by Dr. Bulum?
No, very interesting cases, and very good proof that the pod balloon is very useful, and it makes really complicated bifurcation lesions much more easier. That I will also present a few cases. So I think it's a very good new tool on our shelf for the complex lesions.
Thank you. Normally for left main, I prefer DK crush. But in this case, as I mentioned, because of intramural hematoma on the circumflex, the carina, so I select culotte. What do you agree with me, Dr. Shaoliang?
Yeah, Damras, according to the angiographic and OCT findings, I prefer to use DK quash, particularly when you force the temple to deliver the circumflex stent into the very proximal third field. So I think if you have another balloon in there already to anchoring the delivery of circumflex stent, I think it could be easier. Secondly, My question is that would you prefer to use upper front to stand technique for distal left main African lesion after OCT?
Pardon, can you ask me again?
Yeah, my question is that after circumflex OCT, would you prefer to use upper front to stand technique for distal left main?
Yeah, this two-stand technique for left main, especially when there is a mass. But normally we still use the professional membrane stenting and avoid to treat the side branch. But in this case, it's different because by angiogram, there's no lesion at all. It's significant disease, but by OCT, the MLA of the osseous circle is only 2.8. That is, to me, 2.69. So that is a very critical narrowing for osseo lesion. And two-stand technique is a must. It depends on which culotte or decay crush.
Okay, my second question is that Damras, because of the severe calcification very close to the proximal to the osseo RAD, so it means even after the two-stand technique, after the final kissing balloon inflation, there will be high rate of recoil of the circumflex stent because the expansion of RAD left main stent require very strong forces to distort the circumflex stent. So how long the clinical follow-up for your first case?
Yeah, that's true because from OCT we saw thick calcification when for OCT pullback from LED to the left main. We see thick calcium, and in this particular case, I mean, if we deploy the decay crush or the circumflex first, it might not work. So we prefer that culotte can do, and we do pot. And we make sure that the balloon open as much as possible that you can observe from the OCT finding post kissing balloon inflation on the final one. You can see that the stent is well opposed. And it's quite nearly achieved the circular contour nearly round.
Okay. Yeah, one more question for your second case. Angiographically, there was very severe calcification from distal right coronary artery to proximal segment. Did you plan to use rota before stenting? Can you hear me?
Yes.
Damras?
Yes, I hear you. But in this case, we avoid rota because there is eccentric. To me, rota only work for concentric napkin ring lesion. And second, there is a 90-degree angle. If we want to pass rota in, the rota may go to the soft side, not to the calcium side. They do not do anything on the calcium part. If I have to do debulking, I may use the Scroflex balloon or angioscalp or Wolverine. But rota might not help in this the eccentric calcium.
Yeah, one more question for your second case because the left ventricular ejection fraction was only 37%. My question is that is IVP, ECMO, or Impella routine used for such a particular case?
Yeah, I consider that. Actually, before I did the case, I do LV angiogram first to see that what is the real EF, and it turned out to be only 27%. So when we pass the Y in, there is a EVA graph. So we just be very careful to select balloon pump into the EVA. As I mentioned, there is a friction when I pass the catheter in. That's why we do the angiogram for the iliac artery, but only on right side. I did not do on the left side to make sure. So we went out and we discussed. I said to the relative, I try to be as quick as possible without putting any balloon pump in. And for Impella, it's not possible at all because at the time being when we do the PCI. There is no the ECMO staff around in the hospital, and there is no impella available in Thailand yet. We have only balloon pump.
Okay, I see. I think your first case would be one of the typical case showing the advantage of port balloon for final port technique. Because as I said, because there is a presence of very severe calcification close to the offshore AD. So even after kissing balloon inflation, if the balloon, NC balloon with long shoot to do the final port, which will be very easily to induce the carina shift, I think it will be easier to minimize the minimal stent area as they also show some flex. I think it's a perfect case, perfect. Thank you very much, Damras, my friend, my brother. So I think the next speaker will be myself. Okay, let me share my screen. So can you see my slides?
Yes.
Okay, thank you. My case is pretty easy. So the title is an expected event from a regular case, a nightmare scenario. So it's a very tough career for one of my colleagues. So the patient is 61 years old lady. So the traditional risk factor was only hypertension. Patient presented unstable angina and was admitted to our hospital. So actually, the clinical presentation was the exertional chest discomfort and pain for 5 years and worsened for only 2 weeks. No more specific for laboratory test, BNP normal, EKG normal, left ventricular ejection fraction was 65%. So this is a geography for right coronary artery after implantation of 2 DES stent with sirolimus elute stent. So they find the blood flow, TIMI flow was 3 from 2 different projections. I think no more comments about the right coronary artery PCI. So the left one is epicaudal, show almost normal for some flex, except for only mild plaque at the distal segment of SIR. And the middle one is a IO cranial to show not too severely tight stenosis, bifurcant lesion involving middle LAD and diagonal. Also, you can see there is a mild muscle bridge just distal to the lesion in the LAD. From the spider view on the right panel, you can see left main looks good, proximal LAD looks good. This is 6th branch diagnostic cancer. So the diameter of the left main minimal should be minimally 4 or 4.5 millimeters or 3.5 for the proximal LAD. So my colleague studied the conventional PCI using a gel wire in diagonal, and after pre-dilation using 2.0 by 50 millimeter Mauric balloon. I think Mauric balloon is a very old generation balloon. After that, a 2.75 by 33 Firehawk stent, Fire Kingfisher stent. It's a new generation of drug-eluting stent by Microport, was deployed to try to fully cover the whole lesion length in the middle portion of LAD. So right-hand geography showed very good TIMI flow in both LAD and diagonal. So patient did not complain any chest pain during the whole procedure. So after stenting, so they used the 3.0 by 8 millimeter quantum NC balloon to sequentially post-dilate the whole stent from the middle to the proximal edge of the stent. In the middle angiography, you can see because of the wide discrepancy in the vessel diameter between distal to the proximal LAD, so they used another 2.75 by 50 millimeter quantum NC balloon to post-dilate the distal segment of the stent. After port, so again, so change it to the epicranial, which showed a very good TME flow in both ID and diagonal. Even the ostial diagonal was slightly pinched, but there was no any worsening of blood flow in side branch. So they did not touch the side branch at all. So after that, because the patient was assigned to a bifurcated DCB trial, actually for this case, my colleague did not check the intravascular imaging. So angiographically diagonal is the only large diagonal taken from RAD. And also, according to the study protocol, after stenting main vessel, if the ostial side branch was pinched by almost greater than 70%, so the patient could be randomized to our bifurcation DCB trial. So from the left angiography, you can see one conventional balloon in ID, another DCB balloon in the diagonal. So this is partly tested eluting balloon. After TCB and the kissing balloon for the diagonal and RAD, so they did the final port technique using the previously used 30 by 8 millimeter quantum NC balloon. Also, the right angiography showed a very good TME flow in both RAD and diagonal. The carefully looking, there was no any sign of distal edge dissection. Absolutely, there was no proximal edge dissection. So this is final angiography from LL cranial and AP caudal views. So both angiography did not show any sign of complication, intra-procedural complication. Particularly, from LL cranial, it looks like a very mild plaque as a very proximal RAD. So they didn't touch the RAD much more. So right now you can see 2 hours later after the procedure. So the patient stayed in the conventional ward and presented a very severe chest pain. And simultaneously, EKG showed ST elevated myocardial infarction and also repeat ventricular defibrillation. So you can see massage was done by many times. After that, so the patient was delivered to cath lab again. So the post-procedure angiography showed in the middle panel, you can see the blood flow in the RAD looks like TME1 or TME2. Also, there was a sign very severe spiral dissection studied from the portion proximal to the RAD stent to very distal RAD. So this is very strange, if even there is only proximal dissection because the stent was in its position. So there would be no any sign of distal dissection. So from angiography, the suspicion will be that there were 2 dissections, one proximal to the stent, another one distal to the stent. So on the right panel, you can see my colleague tried to avoid the distal RAD, but without the guidance of intravascular imaging, nobody makes sure if the wire in the true lumen. So they used the 20 by 20 millimeter Moric balloon. It's a semi-compliant balloon to try to restore the blood flow for RAD. After ballooning, from the left angiography, you can see the blood flow from the proximal RAD to the middle part of the stent looks good, but there was very severe spiral dissection distal to the RAD stent. So after that, my colleague exchanged the balloon using microcast into the distal RAD. So tube injection confirmed the delivery of contrast, but not very good distally to the very distal symphysis. So it means probably the wire partially in the false lumen, and probably there was a communication. There was a channel between false and the true lumen. And simultaneously, my colleague tried to use OCT and I was to identify if the wire was in the true lumen, but finally they failed to advance the IVUS OCT case distally. So after that, from the angiography, you can see IBP was implanted, and the heart rate was almost 90 BPM, and also the right angiography showed a normal TIMI flow in right coronary artery. Because after the procedure, because the patient suffered cardiogenic shock with repeated ventricular fibrillation, and the patient was delivered to cardiac surgeon for urgent CABG. But after CABG, the patient still had refractory cardiogenic shock, even and the treatment of ECMO plus IBP. Unfortunately, the patient died 4 days since surgery. So I think this is a simple case, but the final clinical consequence was terrible. Thanks for your attention. Any comment or question about this regular case? It's a terrible case. It's regular but terrible.
So if I may comment, whenever I saw such a tortuous LAD in the female patient, I always am afraid or always afraid to do any complex lesion. But what is strange for me is that the final angiographic result was really perfect. I think that nothing could be seen more on this angio. My only different approach would be after this resuscitation in our center. First of all, I would put the patient on Impella CP immediately. I would use extra backup guiding catheter, and I would insist to finish the case percutaneously. I would not send this patient to the surgery. Why? Because you have dissection below the stents, and nobody can guarantee on surgery that they will put the lima or any graft to the true lumen. So your colleague was on the true lumen distally. He should use extra backup catheter, 7 French if possible, and try to restore this LAD only with balloons, and then leave the LAD open on let's say Impella CP. That would be approach in my center. If the patient will be good, we will try leave the patient for a few days and then finish maybe the angio, or even do ECMO upgrade, but also on the Impella, like ECMELA. You have ECMO support together with left ventricular unloading. So I'm afraid that surgeon couldn't guarantee the graft on the true lumen, and even if the graft would be in the true lumen distally, still you don't have any backflow to the proximal and mid LAD. So I would try to finish this case percutaneously, and the patient would be first put on the Impella CP, and then we would do your colleague did a great job. He was in the true lumen at the apex with the microcatheter. So I was a little bit surprised that the patient went to surgery after that.
Thanks for your great comments. Any comment by Damras?
Yes, I agree that for a corkscrew distal LED, we have to be very, very gentle. And the first wiring is always perfect. But during the procedure, maybe, I don't know, but maybe you may lose the wire and try to rewiring. And that time, where the dissection occurred. So I always tell all the staff when we deal with the corkscrew LED, don't lose the wire at any cost. Keep the wire in the position. When you try to push in and out and stand and do the kissing balloon inflation or whatever, we cannot lose wire, because when we pass second time, the wire is always dissect, and we try to avoid those polymer jacket wire. we try to use just a floppy as much as possible. I regret to see that result you do on the first angio is perfect, but it may happen when we handle the wire not so properly, especially when you have assistance, and they may lose the wire or at some cost, at some reason they lose the wire and try to pass the wire in, repass, and then it causes the complication.
Just one more small comment. I don't know, do you have any experience, but I have 2 to 3 cases with dissected LAD and then the wire was lost for any reason. And I have to tell you that the SUO3 wire saved my day. So SUO3 wire, from my experience, is the best wire, especially in the LAD. When you lose the wire from the dissected LAD, it is the wire that gets you the more chances to go to the true lumen, SUO3. So I don't know, did you ever try to do it in that scenario? But it is really helpful. I try with all the wires, and then when I take the SUO3, it just slipped to the apical LAD in the true lumen. It can be very helpful.
Agree. SUO3 for the collateral channel, the wire tracking, it helps, but it's not strong enough. When you have to penetrate something, but it's go to the very corkscrew the contour.
But once you reach the apical LAD, you do reverse trapping, and then you exchange the SUO3 for any wire that you want to, let's say, finish the procedure. But it can really gently go back to true lumen sometimes, especially in this curved LAD. This is the worst LAD. Whenever I see these tortuosities, you can expect really nightmare complication, because you are limited to go back to true lumen again, because so many tortuosities in the vessel.
And if I have to do this case, I will not pass the wire through the very distal part. I just pass only the first or second curve. That's all. That's enough to give you support to do the stenting on the mid LAD. Don't go down to the very, very distal and you lose the LAD.
Yeah, absolutely. Thank you for your great comments. Actually, self-criticism came from the many mistakes into procedure. First, as Damras said, even the lesion is pretty critical around the bifurcation area, but also there was a muscle breach distal to the lesion. So my colleague chose the long stent. That would be very dangerous to get perforation. Secondly, stent diameter is 2.75. They use another 2.75 NC balloon to post-dilate stent. It's reasonable, but for the lesion with the presence of muscle breach, it could be very, very dangerous to get again perforation or distal dissection. Secondly, I think this case provided the advantages of the port balloon from different perspectives, particularly for the proximality of stent. So they used the 3O NC balloon. So angiographically, the proximal LAD diameter should be greater than 3O, because 2.75 for LAD and 2.5 for side branch. So the proximal diameter should be greater than 3O. But because there was a mild plaque at the proximal LAD, so after the post-dilation, so also there was a proximal dissection. So I think it could be explained by two dissections, proximal true and distal to stent edge. It's not common, but I think it's not rare. If we didn't pay much more attention to the geographic anatomic analysis for any kind of lesion. So number 3, I think, is that because they did not use intravascular imaging even during the rescue PCI. Number 4, I think, is that after tip injection, so some of the wire was in the true lumen, some not sure. But personally, I'd like to push the LAD wire as distal as possible, and then perform the tip injection. If the distal wire was in the true lumen, I'd like to use multiple stents to cut from distal to the proximal stent edge. That would be much better than cabbage As Joško said, I think cardiac surgeon could not find out which one is the true lumen of AD. It's impossible. So I think this is maybe the reason why the patient died after the KBG procedure. It's a terrible case. Patient was pretty young, only 61 years old. And also finally, I'd like to say, at that time, in my case lab, there are only 3 impellers. So all impellers were in use, so no choice. So they used the IBP and ECMO. So I'm sorry. So thank you very much. If there's no more comments and questions, so I'd like to invite my friend, Dr. Joško Bulum, to present your case. Thank you.
Thank you very much. Once more, thank you for the invitation to such a esteemed workshop. Just a second to find my presentation. It's my privilege to be here with some of the most known experts for bifurcation lesions and complex lesions, like Professor Chen and Garbo. And I would like to show you our first initial experience with the BrosMed pot balloon in bifurcation lesions. I'm coming from Zagreb. Zagreb is the capital of Croatia. If you don't know, Croatia is small but very beautiful country on the Adriatic Sea, and we are sharing the Adriatic Sea with Italy. So if you would like to visit us, you will be my guest. When you look to the bifurcation lesions, the bifurcation lesions are one of the key elements of the complex coronary artery disease, and we all know it. And although the bifurcation is very well known and our Medina classification is very well known, we know that in the everyday practice, especially I would say in the Europe PCI community, there are everlasting debates about bifurcations PCI. Should be insist on provisional, should be go to complex 2-stent techniques. But when we look to the field, when you look around, I'm proctoring a lot around, you can see that using 2 stents complex technique is not all the operators are very well skilled in that area. Some general principle to the bifurcation lesions is to choose between the provisional technique, stenting only the main vessel, but in the case that the likelihood of the side branch occlusion is very high, especially in the very narrow angulation, we have to use planned 2-stent strategy techniques. In the Croatia, and I think in lots of Europe countries, now 2 techniques prevail. It's T and protrusion in the wide angles, and it's DK crush technique in the narrow angle. So I would like to present altogether 3 very short cases in which we used pot balloon, and in which cases we find pot balloon very, very useful. First was 64-year-old man, arterial hypertension.
I'm sorry.
So I will be very quick. As I said, bifurcation lesions are one of the complex lesions. Medina classification is very, very clear. And today, in our center in Croatia, in this part of the region in Europe, we choose between the provisional stent technique, and in the case of 2-stent strategy, most commonly used techniques are T and protrusion and DK crush. So the first case was a 64-year-old man with arterial hypertension and dyslipidemia, and this patient was, I think, only 2 weeks ago. He was transferred from the county hospital because of the non-STEMI. The echo was normal, and he was transferred to our center for coronary angiography. And the coronary angiography during on-call, so it was late afternoon, shows subocclusive mid-dominant RCA. You will see that RCA artery is very large, and with additional critical ostial PD stenosis, Medina 001. So as you can see here, left system is really non-dominant without any stenosis, and the right coronary artery is very dominant. We have probably calculated lesion in the mid RCA, but also additional very tight ostial PD stenosis. Although the PD is most commonly the main branch, in this case, the PL is the main branch because you can see here it's huge. It really irrigates the large portion of the lateral wall. So the younger colleague was starting this procedure, and his strategy was to do the stenting of the mid RCA and to try to resolve these ostial PD lesions with the DCB only technique, which is preferred technique in our center typically for the ostial lesions of the small side branches. So the procedure was done with the 6 French system with the normal Judkins right guiding catheter. And as you can appreciate here, despite multiple predilatations of the ostial PED, first with NC balloons, scoring balloons, and at the end with the cutting Volver in 3O balloon, the angiographic result was not satisfactory for the DCB only technique. So at that moment, he asked me for the help, and we had to switch this procedure from the, let's say, simple PCI DCB only to two-stent strategy technique. When you look the general principle for the bifurcation lesions, in the case of important discrepancy between the sizes of the 2 branches, which is in this case because the PD was maximum 2.75, but the PL was at least 3.5. This is the case for the crush, or today for the DK crush technique. So when you look from Manos Bilakis, which is very popular among younger pathologists, when you want to do the DK crush, you have at least 17 steps, 2 of them being pot. So this procedure was done with the same 6 French system. We put the Ultimaster 2.75 stent in the PD, and this stent was crushed with a 3.5 NC balloon in the distal RCA. And after that, the first kissing balloons were done using the Accuforce 2.75 and Accuforce 3.5 NC balloons. After that, Ultimaster Tansei 3.5 was implanted in the main branch, and then the first pot with the BrosMed pot balloon was done, 4.06. You can see here that due to some movement, we had very, very small stent portion in the pot position. So the pot position should be very precise. We need very short balloon, and we have to have balloon without any balloon enlargement to the balloon border, as you can see here. Very, very precise pot. Enabling us to do the recrossing. We did the second kissing balloons using 3.5 NC balloon in the distal RCA and 2.75 balloon PD, and it was finished by the final very, very precise pot you can see here with 4 or 6 BrosMed pot balloon. So the final angiography was perfect, and the patient was released home next day. In the mid RCA, after doing this bifurcation stenting in the crux, we implant the Zions 4 or 38. The second patient was 78 years old man with arterial hypertension, dyslipidemia, type 2 diabetes. And this patient was transferred also from county hospital in the April this year to our hospital because of high risk non-stamine. He had indeed progressive ongoing ischemia. So the urgent coronary angio was done. That revealed borderline distal left main stenosis, but the carpet lesions was acute thrombotic mid LCA occlusion, and the primary PCI, the circumventory, was done with one drug-elutic stent implantation. We decided in these patients to wait until 3 to 4 days in the same hospital stay, and then to do the coronary angio, repeated coronary angio, and the OCT of the left main. It was done by the transfemoral approach, 7th French. You can see here, extra backup for all guiding catheter. As you can see here, after this angio with the nitro, that with the angiography, this stenosis is significant, but we also prove it with the OCT, and we find the minimal lumen area on 5.2 in this distal left main stenosis. So we decide to proceed with the OCT guided PCI with the left main with the DK crush technique, which is, as I previously mentioned, our preferred 2-stent technique. So the predilatations were done with the NC 3O balloon and the scoring 3O balloon. As you can see here, from this case and also the previous case, at our center, we use lots of scoring and also cutting, and we don't hesitate to do the shockwave balloon to prepare the distal left main lesions if we find some calcium on IVUS on OCT. So after the predilatation with the NC and scoring balloon, we implanted Ultimaster Tansei 3O28 into the left circumflex artery, and we crushed the stents with the 3.5 NC balloon, as you can see here. But after the crushing, we were unable to recross with the Zion Blue wire into the left circumflex artery, and then we did as you can see here on this clear stent image, very, very precise additional crush, but in the pot position with the BrosMed pot 4 or 10 balloon. As you can see here, it is very precise crash only of these crushed stents. Why? To enable our wire to recross through the stent strut and not to recross under the stent trunk. After that, we did immediately successful recrossing with Zion black wire. After that, the first kissing balloon was performed using 3.5 and 3.0 NC track balloons. After that, we did the first proximal optimization techniques again with the with the same BrosMed 4 or 10 balloon, as you can see here. After that, recrossing second kissing balloons inflations and followed by final pot, this time with 4.510 BrosMed pot balloon. And you can see here, we were able to obtain really the optimal angiographic result. And the third case was pretty young women patients, only 47 years old, with arterial hypertension, dyslipidemia, but very pronounced early onset familial coronary disease. Lots of relatives had coronary disease with the ages earlier than 50 years old. So also in the May this year, she reported the new onset effort angina to her cardiologist. Echocardiography was perfectly normal, preserved ejection fraction, no any hypokinesis. So she was sent to CT coronary angio that revealed borderline ostial LAD stenosis, and these stenoses were characterized like unstable plaque by the CT coronary angio. So she was sent to our center to coronary angio, and we found significant ostial LAD stenosis, which is indeed Medina 010 bifurcation lesion. So this is the coronary angio. It was right transradial 7 French approach using light sheet slender 7 French. And you can see here this Medina 010 stenosis. So in this case, our strategy was to do IVUS guided PCI to left main, but with provisional technique. We know from many studies, this is just one bifurcation stenting registry, that when we do the left main bifurcation stenting and we need to use 2 stents technique, very often because the bifurcation itself was very complex, we will have increased ratio of target lesion failure in the case of 2 stent techniques. And also 10 years syntax trial follow-up clearly showed us that if at least any one bifurcation, whether it is left main or not left main stenosis, is treated with a 2 stent technique, then on the very, very long follow-up, up to 10 years, we have cumulative indices of all-cause mortality increased. So the authors suggest, and this is also our approach at our center, the one stent strategy, if possible, should initially be the preferred option for the treatment of the left main bifurcation lesions. And when you look the bifurcation club recommendations, the most important step in the provisional stenting is to do proper proximal optimization technique after the main vessel stent implantation. So in these patients, we also use scoring balloon NCA alpha 3.0 to prepare the ostial LAD lesions. Then we do the IVUS, and following the IVUS findings, we decide to implant ultimacetan say 3.5 over 24 drug-eluting stents. After that, we did the first pot with BrosMed balloon 4.56, recrossing kissing techniques, 3.5 NC into the circ and 3.5 NC to the LAD according to IVUS findings. And we finished the final pot using a little bit shorter to 4.58 balloons. And as you can see here, we were able to obtain really optimal results. So to conclude very briefly, the pot balloon in our center, in our initial experience, really proved to be very, very effective tool when dealing with these very complex bifurcation lesions. I would like to thank you for your attention.
Thank you very much, Dr. Bulum, for your wonderful 3 cases. I did not find the 17 steps of DCAT question, but only 7 steps from your 2 cases. So I trust you are much. You are much experienced than me for DK positioning. Yeah.
You know.
Thank you. Just two quick questions. First one is for left main disease. How do you select IVOS guidance or OCT guidance?
So in the case of distal left main stenosis, and in the case of, let's say, narrow left main without any strange curves, I would prefer to do OCT guided intervention, because the OCT give me much more information, especially about the calcifications like that was shown in the previous cases, and because then I would not hesitate to do the shock wave IVL before the PCI. But in the case of the ostial left main stenosis, very short left main, very narrow left main, I would prefer the IVOS, because then I can do pullbacks to the ostium. I don't need to apply contrast, and the procedure itself is much more simpler. And also sometimes in the case of very curved surfaces artery, I would do IVOS, because simply from my experience, OCT catheter shown to be not so rigid enough to be pushed to the circulus artery when the angle is close to 90 degrees.
Thank you very much for your response. Welcome, Dr. Garbo, for joining us right now. Thank you. Dr. Bulum, my second question is that from your third case, after provisional, after standing main vessel angiography, there was no more severe pinched single flash. So question is that, how do you often to do kissing balloon inflation after provisional with one stent?
So in the cases that the right coronary artery is dominant, and the left circulus artery is not so large like this one, I would finish only with the pot. But in this case, it was clearly so that the left circulus artery is large artery, even larger than the LAD. So in the cases like this, I would prefer to do the kissing, especially because we find any disease on the left circumflex. So I was strongly convinced that I will not do any damage or dissection or have to convert these provisional to two stent techniques after the kissing. But in the case of small left circumflex, I would finish only with the pot without recrossing, because we don't have any clear evidence that this kissing will decrease any hard endpoint at the follow-up of the patients.
Yeah, I fully agree. I think this is a very important point to tell our audience for very dominant single flash. After left main standing, even there was no any sign of severe disease, as they also show single flash. Kissing balloon inflation could be another option. Damras, do you have any comments or question?
Yeah, I'm interested on your last case where you do the kiss pot. I mean, normally, if you do the provisional stenting on the main, and if there is no pinching on the surface, do you really need a kiss, or just only pot, provisional stent and pot? Is that all, or you need a pot side pot, a pot kiss pot?
So in this case, pot kiss pot was done only because the left circumflex artery was very large. Otherwise, I would finish with the first pot because there was no any pinching and the result was perfect. The circumflex was simply too large to be left without kissing, so we prefer to leave this left circumflex for any potential re-intervention in the future.
Yeah, if I can make a comment, congratulate for your great presentation. I think that the two key points are the size of the side branch. This is really important, and then even the result we can have on imaging. So depending on imaging, and this is really important. If you have very good results, and you can avoid the last kissing. I agree with you. Yeah.
Thank you.
Yeah, I fully agree with the kissing balloon inflation for very large flash after standing main vessel. From my experience, there were several cases after standing ID to left main without final kissing balloon inflation. During clinical follow-up, patient present very severe chest pain, but angiography could not find out any disease as they also show third. But if we recheck the OCT, there are at least 1 or 2 struts just covering only ostium of syphilis with some materials only surface of the struts. I think there will be a problem. So it means for some case, probably we need to do final kissing. A final patient, Dr. Bulum is there for DK quality. Actually, for any kissing balloon inflation, we always recommend to keep the overlapping length of two balloons in the main vessel as short as possible. So how do you keep the balloon length? 2 millimeters or 3 millimeters or even long overlapping in the main vessel?
I prefer to do minimum protrusion to the main vessel and then to finish with the final pot only in this portion of the stent in the main vessel.
Thank you. So thank you once again for your excellent cases. So now it's the time to invite Dr. Garbo to present your cases. Thank you.
Yeah, thank you for the invitation, Professor Chen. It's a great pleasure. And I will try to show. You can see my slide?
Yes, please, full screen play.
Okay, great. So this is my last CTO PCI. So it's a PCI of 6 days ago. And it's nice to show because we have many tips and tricks and interesting point for discussion. Is a complex patient, a 72 years old male with several risk factors and a very old coronary artery disease history starting 20 years ago. So with the non-STEMI 3-vessel disease, was treated with PCI on the circ in 2003. Then in 2006, he has an treating of with the rotational atherectomy for severe calcified stenosis on the right. So rotational atherectomy and drug-eluting stent on the right. Then after 3 years, because of occurrence of severe angina and severe ischemia on myocardial scintigraphy, the coronary angio show a double occlusion of the circ at the ostium and of the proximal right inside of the first stent. So we have a complex patient, 2 occlusion, and so it was treated by surgery. So coronary artery bypass with 3 saphenous vein grafts on the PDA, first diagonal, and OM. Then in 2011, there was a new angio that show failure on the graft and failed PCI CTO on the circ. And then we go to this year. So March of 2023, again, worsening angina and ischemia. The angio show occluded graft to the PDA and OM. And the only graft patent is on the first diagonal branch that feeding part of the OM. Then the left main, you will see it was defined borderline stenosis and 2 ostial, 2 occlusion, the circ and the proximal right. The magnetic resonance show no viability in the circ and severe ischemia and viability in the right. So because of the very good normal ejection fraction and because of the clinical condition, we schedule a second attempt on this complex right occlusion. Just try to go. This is the first shot on the of the situation. You can see the right, you will see better later. and we have a sort of tree occlusion. The proximal right is occluded until the distal PDA. Then we have another occlusion in the ostium of the big posterolateral branch. So we have a tapered proximal cap, but very long occlusion, and the second severe long calcified occlusion of the ostium of the posterolateral branch in bifurcation with PDA, a good retrograde collateral, and previous anti-gate failure. So this in my mind was an IVUS guided left main evaluation and complex RCA CTO PCI with all option anti-gate and retrograde. If you can see, this is my first shot of last week. We have left main that is for sure not a good left main. Then if we think about retrograde option, we know that we need to avoid ischemia of the donor vessel. So my first plan was to evaluate very well the left main and to treat the left main before starting the right CTO. This is the LAO projection that show that the left system feed the right artery with a very complex occlusion at the level of distal right. You can see we can see the PDA from one septal, we can see the posterolateral branch from the first septal, but the occlusion is really long. So we evaluate with IVUS. You can see this is the pullback that we perform for the left main. We can see that is a really critical stenosis. The MLA was 3.7 at the level of left main. We can see even at 12 o'clock the circ occluded and the calcified lesion. So we start to predilate the left main, then we stand with 3.5 and we perform a pot. You can see here at 28 atmosphere with a BrosMed 4010 for 10, and you can see here, and you have seen in the previous case that the shoulder of the pot remain really short, even if you go up to 28 atmosphere. And this is really important. We can skip this slide about the difference between regular balloon and pod balloon. We know how really perform very well this kind of balloon. I use a lot even for pre-dilatation as a classical non-compliant balloon. You will see later. We can go really at high atmosphere, and we have no deformation of the balloon, even up to 30. I went in this case, you will see up to 32 atmosphere without any rupture of the balloon. So and then you can use again. So you have very good, even a good refolding. So we have talking about POTS as post dilatation inside of the stent. We have really a precise positioning of the device. And then for the IRBP, on respect to the other non-compliant balloon, I've seen that I have more force to have very good force inside of the stent to post-dilate, and then no deformation of the device. This is the angio after the post-dilatation with 4.0, and this is the IVUS, very good IVUS, and even in a calcified post-cabbage patient. And then at this point, we were able to start the right. So this is the bilateral angio. We know that dual angio is essential in CTO. We need to know where to go. And for a safety, we cannot start a CTO without dual injection if we have a retrograde connection from the other vessel. So this is a turnpike spiral, and I try to start with the Gaia third, but we have even a sudden buckling of the wire because we have no force to puncture with the Gaia, and then I switch very fast to the Gladius EX. As you can see on the right, the Gladius EX make very good progress inside the plaque, inside the stent, that was occluded, and then we have very good progression of the vessel. Even you can see I need to push a lot. This is Amplas left 7 French. This case was done by biradial 7 French access with the Gladschist lender, and but even with the Amplas, I need to push a lot in order to advance the Gladius. And then on the right, you can see the Gladius went quite easily in the PDA. So the first part of CTO I was really happy. That was quite fast, and I was able to advance the turnpike spiral. The Gladius gained the PDA. So the first part was done. You can see this is the angio from the left. We reached the PDA, and then you can see here better how calcified is the ostium of the posterolateral branch, a second really long occlusion, and with a big vessel. So we need to open this posterolateral branch. The first option in my mind was try taking dual lumen catheter and try to puncture from antegrade. And this is the time which the fluoroscopy registration of the attempt to puncture with dual lumen with the Gaia and the Gladius, but I failed. I have no chance to engage the ostium of the occlusion. So at this point, the only chance was switching to retrograde from the first septal. This is the SUO03. How fast the SUO03 cross this complex septal connection. Then I advanced the Gladius very well at the level of the CTO at the bifurcation. You can see here the Gladius entering the Amplatz guiding catheter. So I did a great retrograde crossing with the Gladius EX. So the Gladius was very good in antegrade and very good in retrograde. This time we have 2 chances: the externalization of the tip-in strategy. I choose this second option. So this is the tip-in with the Gladius and the antegrade microcatheter, and then I advance the turnpike spiral over the same Gladius, and in order to change the wire, I gain the posterolateral branch. I put the IVUS on the PDA just to understand what happened with the previous stent. And what we can see that we have underexpanded previous stent, a huge calcified vessel, and you can see this is the all the pullback. And even in the proximal part of the eye, you will see huge calcification. So like here. Great. And the previous stent is really underexpanded. This is the calcium, 360-degree calcium at the level of the proximal part of the right. So in this case, it's really essential to have a very good preparation of the vessel. And I decided to use the pot even for the preparation. You can see the first shot. We have the pot 3-0 at the level of bifurcation. We did even a kissing balloon with another non-compliant balloon on the PDA, and then we went back with the different pot 3-5 4-0 balloon in order to open very well the vessel and the previous underexpanded stent up to the ostium of the right. Then we have a problem. We have during the trapping maneuver, we have a rupture of the balloon, and then I lose the wire on the PDA. So you can see here, this is the critical situation because we have PDA without any wire, and we have the flow impairment of the flow in the PDA. We have a wire on the posterolateral branch, and then again dual lumen with several attempts. At the beginning was not so easy. I went in, saw that I think there was a side branch of the PDA, and then I was able with the dual lumen and Sion black to get the PDA vessel with the wire. Then mini crush technique, you can see here. So the first stent was a 275 in the PDA with a trio balloon in order to on the posterolateral branch, because I decided that the posterolateral branch was the main vessel in order to get the root and to performing mini crush considering the posterolateral branch as the main vessel. So stenting the PDA, ballooning the posterolateral branch, then second stent in the posterolateral branch, and then other stent up to the ostium. This is the angio after stenting a post-dilatation. You can see there's something strange at the level of the PDA. I don't know if you're able to see. There's a perforation. So this was done by the attempt to get the wire in the PDA. And as you know, the post-CABG patients are really complex even in that situation, because you can have a dry tamponade that is really dangerous, and so you need to be really careful even in this kind of perforation. So we perform echo, and we start to see a small hematoma at the level of the conversion between the right ventricle and the right atrium, and the hematoma was growing. So in this case, you need to close for sure the perforation. And the best way in order to save all the branches is putting a coil in the level of the hole. So I advance the gladius inside the hole, I advance the turnpike spiral, and then I put a detachable 20 millimeter per 40 millimeter microvention coil. This is the time of deployment of the coil inside of the perforation. In this way, you save all the branches, and this is then all the potting with the BrosMed pot balloon of the vessel. So 3.5 per 10 in the distal right. Then we have a 4.0 balloon in the mid of the right, in the proximal right at 32 atmosphere, as you can see in the picture, and then with a 4.5 balloon at 30 atmosphere at the level of the proximal and ostial part of the right. This is the final result of our vessel. I think it's a very good result in all the right. We have a disease. We leave the disease in the PDA that was present at the beginning. You can see the coil in the level of the hole. We can see very good posterolateral branch. Then, of course, we check the left system in order to be sure, to be safe, that we have no damage of the septal that we use for retrograde approach. So we have the last shot on the left, and then we have the final IVUS pull back. As you can see, very acceptable result of our multiple stenting, and I think a very good result that of our post-dilatation in this really complex vessel, calcified vessel with the previous stent failure. Even the proximal part of the right is really good, as you can see now up to the ostium. So to conclude, my final comment, if I'm able to go to the final slide. Complex CTOKs need really a careful evaluation, hybrid approach with operators' great expertise in order to be really flexible. And during the procedure, you need to change strategy very fast. So don't stay in a failure mode for time, and be able to change strategy, and careful evaluation of possible complication that can occur during the procedure. IVUS was essential in this case. I have more than 70% of IVUS guided CTO PCI in my experience. Last year, I did more than 270 CTO PCI. And then even in the left main was really good. And BrosMed pot and C balloon show great performance for both aggressive pre-dilatation and optimal stent post-dilatation. Is my favorite balloon for this purpose. Thank you very much for your attention.
Thank you very much, Dr. Garbo, for your wonderful cases with left main disease, severely calcified lesion, multiple KVG and PCI, 2 CTOs. Any comments and questions from my 2 friends?
Only congratulations for really impressive case. Just one question: which type of coil you have implanted through the turnpike?
Yeah, this is a very good question. I use detachable coil 0.10. You can use in every microcatheter. So the very important point that this is because when I'm going proctoring outside, I can see that in many cath lab, the operator has no experience on coiling.
Yes.
And this can be a really problem because as you know, you can have perforation of a side branch even during primary PCI. And if you know how to, if you have coil you need to have coil on the shelf in your cath lab, and you need how to use. If you have seen the first time, then you know that it's really easy to put coil. And you can use 0.010 detachable coil like Striker, like Microvention, like EV3, like Concerto. You can use in all microcatheter, even the Caravel, even in the Corsair or Turnpike. And you can use even what I published, that the technique of putting a balloon and then proximal to close the hole and then release the coil distally, so you are safe, and you can do this kind of strategy. So it's really easy and effective. So then, but you need to know that.
Yes, thank you.
Thank you. Just one quick question, because the perforated vessel looks like very small. So in my lab, sometimes we prefer to use the expandable sphere to inject from the microcatheter or even any other delivery catheter. It also functions very well. Damras, do you have any comments or question?
No, that's a great case. We also do use coil, but in our lab, you only use the 016 coil pusher. To me, sometimes 010 or 010 or 014 is too small to put a coil in. So we prefer 16, or sometimes we call tracker 16.
Yeah, the problem that with the 0.10, and you can have even bigger coil, and you can use in every microcatheter. So you don't need to change microcatheter. So you have a microcatheter because you are doing CTO, and you can do, even as I told you, with the block and delivery technique, even with 6 French, you can block your microcatheter and you can release the coil. So it's really a really fast procedure, very effective. And but I think I show that because it's my last case, and even in this kind of complication, and you need to when you're doing CTO in complex case, you need to really don't lose your concentration during all the procedure, because you can get a great result and then you can have a bad complication. So watch really carefully all the step of your procedure, and then have the echo in the cath lab, and then the patient was observed for 48 hours, and the hematoma was stable, and he has no hemodynamic compromise, and but because we didn't lose time before coiling. If you lose time, if you stay 2 hours with the perforation, then you are in trouble, because this kind of hematoma can compress the right ventricle, and then this can be really a problem to solve this kind of hemodynamic shock, because you have no blood to drain and only the hematoma, and this can be really a problem. If you know, in the open CTO registry by US guy, more than 1,000 of CTO PCI, you have 9 deaths in hospital death, of which 6 were by post-cabbage perforation, and that's try to explain how is can be dangerous perforation in a post-cabbage patient.
Okay, Dr. Garbo, one more question for your case. Even CMR confirmed the evidence of ischemia and viability in RCA area. So, which lesion should be the culprit lesion for this patient? I mean, left main disease or RCA-CTO?
No, can you repeat the question, Professor Chen?
Yeah, even CMR confirmed the evidence of ischemia and viability in RCA area. So for your case, which lesion should be the culprit lesion? I mean, left main disease or RCA-CTO?
This is a really good question. So I think that in this case, I don't know that. So you know that when I've seen that left main, I say that we cannot avoid to treat it, because I know that I need to go probably retrograde for sure. And you know, by experience, if you start a complex retrograde and you have ischemia in the donor vessel, this can lead to a crash of our patient. We should be really interesting to treat the left main before, and then to perform again magnetic resonance to show if we have still ischemia on the right after treating the left main. But I'm confident that with this kind of huge right, very long occlusion, and the right is really ischemic in this kind of patient. So, and it was really severely symptomatic. So here cannot do 50 meters without angina, even in maximal medical therapy. So I think that now we did a complete job, great. So left system and right system open, and I think that we will perform again our magnetic resonance in 6 months, and we are confident to have a very good result.
Thank you very much. I think we are slightly behind the schedule. So I think it's time to conclude our session. Thank you very much. Thank you, Dr. Damras Tresukosol, Dr. Joško Bulum, Dr. Garbo, for joining us to discuss, show your experience, to show your knowledge about a very complicated PCI case. Also, we appreciate BrosMed to provide this platform to exchange our experience about the use of pod technique, pod balloon for real complex PCI case. Hopefully next time we can get together and discuss much more. Thank you very much. Thank you.
Thank you very much. It's a pleasure. I hope to see you again soon.
Thank you.
Thank you.
Bye. Pleasure.
Bye-bye.
Bye-bye.
Bye-bye.